The next presenter is Sorelis Rosa, and she will be presenting Mr. Incredible. This is the fourth of our 6 presentations. Thanks.
Okay. Good afternoon. I would like to introduce Mr. Incredible. Mr. Incredible is a 94-year-old African-American male who lives alone at home in an assisted living apartment. There are no stairs to enter the building or to his apartment, and before being admitted into the hospital, Mr. Incredible was ambulating with a straight cane throughout the community. Mr. Incredible's past medical history includes cerebral vascular accident, which occurred 50 years ago, which left him with right side weakness, hypertension, a GI bleed, which was complicated with a myocardial infarction earlier that year, ventricular tachycardia, benign prostatic hypertrophy, which is an enlarged prostate, bilateral hip replacements, and a hernia repair. Here are some facts on hypertension regarding Mr. Incredible's culture and age. Hypertension is twice as prevalent and more severe in African American groups. There is no exact reason as to why this is so, but based on an article by Russer et al., they mentioned that it was due to diet as a key factor. Along with culture, Mr. Incredible's age can be a reason for his hypertension. As we age, our diastolic blood pressure begins to plateau while our systolic blood pressure often starts to rise. After Mr. Incredible began to notice a change in his bowel habits, blood in his stool, and abdominal pain, he decided to go for a checkup, where a biopsy revealed symptoms secondary to colon cancer. According to Codner et al., cancer of the colon and rectum is second only to lung cancer as the leading cause of cancer-related deaths in the United States. Here are several risk factors for colon cancer. The first one is bolded because Mr. Incredible was very much over the age of 50. Listed above are some symptoms that may occur if a person has colon cancer. In Mr. Incredible's case, he had 3 of the symptoms listed: a change in bowel habits, blood in his stool, and abdominal pain. Although Mr. Incredible had a list of comorbidities, these 3 were ones which could greatly affect physical therapy treatment. Along with ventricular tachycardia, hypertension, and myocardial infarction, it's important to remember that Mr. Incredible has also right side weakness secondary to his CVA. So as physical therapists, we want to be aware of the differences from right to left side and try to maintain any strength that remains on his right side. Exercise often increases cardiac arrhythmias, and although a patient may be on medications to control their arrhythmias, the medications may only be effective during rest. Therefore, monitoring a patient's heart rate and blood pressure before, during, and after treatment is important. Chronic exercise often decreases blood pressure and strengthens the heart muscle, but as mentioned with ventricular tachycardia, monitoring a patient's blood pressure is key, as well as their vitals. Listed above are some signs and symptoms to be aware of if someone has ventricular tachycardia. Now, if you go down the list, you may see some signs like shortness of breath or tiredness, and that may be secondary just to overexertion after exercise. But you just want to stop, monitor, and make sure that everything's okay before you continue with treatment. With that said, here are some signs and symptoms to watch out for a person who has myocardial infarction. On this slide are 2 medications which Mr. Incredible was taking for his hypertension: metoprolol and Cozar. Metoprolol is a cardioselective beta blocker, and Cozar is an angiotensin II receptor. I bolded the side effects in pink, which you should be cautious about if they were to occur. And because these are both antihypertensive medications, decrease in blood pressure or hypertension could possibly happen. So you want to make sure that the patient's not getting pale or faint-like. Flomax, which is an alpha-1 antagonist, was being taken for his benign prostatic hypertrophy. And with this medication, you want to be aware of orthostatic hypertension, so it's important to make sure that when moving from different positions, you do so at a slow pace. Amiodarone is a class 3 drug which delays repolarization of cardiac cells, and this drug was given secondary to his ventricular tachycardia. Some adverse reactions to watch for with this drug can be that it can decrease coordination and cause tremor, which can affect balance as well as cause fatigue. And again, you want to watch out for hypotension. Vancomycin and metronidazole are two antibacterial medications which Mr. Incredible was taking secondary to catching an E. coli infection during his hospital stay. With vancomycin, you want to be aware, again, of hypotension, as well as increased muscle spasms, which can affect his range of motion. And with metronidazole, you want to be aware that this drug could possibly cause seizures, as well as decreased sensation, which can affect his proprioception. So what do you want to remember, especially with a patient with such an extensive cardiac history? You want to monitor their vitals, be aware of their comorbidities, and know what medications they're on, as well as the side effects. And most importantly, you always want to observe the patient. You want to look at their facial expressions. Do they look like they're in pain, or are they turning pale on you? Based on Mr. Incredible's past medical history, you may think that he was a weak and sickly man. But despite all of these comorbidities, he presented as an energetic and motivated person. Mr. Incredible was transferred to a local hospital on June 12, 2007, where a stress test was performed along with a thallium heart scan to determine if the blood was flowing properly. Results indicated cardiac clearance, and we could proceed with laparoscopic assisted colectomy. Not only was Mr. Incredible 94 years old, but he also had several comorbidities. So the question was it ethically right to allow Mr. Incredible to undergo surgery? In my opinion, I believe yes, and this is why. In an article by Bailey's et al., several areas were to be assessed before allowing an elderly patient to undergo surgery. Based on this article assessment, Mr. Incredible should be allowed to have surgery because he demonstrated a healthy appearance, he had good nutritional status, he was cognitively aware of what was going on, and even though he had several comorbidities, they were well under control. And besides the tumor, he had no abnormal test results. However, with that said, this article also found that elderly patients with 3 or more of the following were at higher risk for cardiac complications. The ones that are bolded are the ones that Mr. Incredible had. So why proceed with surgery? Well, as I mentioned several times, Mr. Incredible is a motivated patient. He's alert, conscious, and well aware of the risks as well as the recovery process after surgery. Laparoscopic assisted colectomy is appropriate for any one of these diagnoses. Laparoscopic assisted colectomy is a type of minimally invasive procedure. The procedure begins with 3 1-centimeter incisions into the abdomen. The incision is then lengthened to 3 to 5 centimeters, and the colon is removed. Once the colon is removed, the infected portion is cut off and the 2 disease-free ends are reconnected and reinserted into the abdomen. So what are the advantages for this type of procedure as opposed to a traditional open colectomy? Smaller incisions, shorter hospital stay, decreased pain, fewer post-surgical complications, decreased blood blood loss, and an overall quicker recovery. In an article by Lacey et al., patients who underwent laparoscopic assisted colectomy were compared to those who underwent traditional open colectomy. Both groups had similar baseline characteristics and were both placed under general anesthesia. Postoperative management included frequent visits to check for the patient's symptoms and wound scars. Results concluded a lower blood loss, faster recovery, decreased surgical complications, and higher probability of cancer-related survival in the group that underwent the laparoscopic assisted colectomy. So why is this important for physical therapists? Basically, by starting physical therapy earlier and with less pain, it can decrease further complications from occurring and therefore allow for a smoother and more effective physical therapy treatment. Given Mr. Incredible's cardiac history, I was curious if a pulmonary artery catheter was used during surgery. This catheter measures pressures in the heart and can detect heart failure. In a retrospective analysis by Kavarian et al., elderly patients who underwent surgery using a pulmonary artery catheter were compared to those who underwent surgery without. Patients were divided based on Goldman's cardiac risk index. And above, those were the risk factors that were included. Next to each one, there's a number, and the higher the number, the higher of a chance for cardiac risk factors. The groups were divided into two, and those who had scores over 10 were in one group, and those with scores less than 10 were in another group. Results concluded a 75% reduction in mortality in patients with Goldman's cardiac risk index of 10 or more who had a pulmonary artery catheter in place during surgery. Because Mr. Incredible falls above 10 in terms of his cardiac risk factors, a pulmonary artery catheter may have been beneficial for him. After talking to Dr. Sanko, an expert in the field of cardio, he was wondering if spinal anesthesia was given during surgery as opposed to general anesthesia. General anesthesia produces an absence in pain sensation throughout the entire body, and although it's necessary for many complicated surgeries, it can have serious cardiac complications. With that said, spinal anesthesia also blocks pain, but instead of doing it throughout the entire body, it's more localized, and the risk of cardiac complications are decreased. On June 19th, a referral was received to evaluate functional mobility and encourage ambulation. By having physical therapy before surgery, it kept Mr. Incredible moving and gave him a baseline, and gave us a baseline of where he was before going into surgery. During the initial eval, Mr. Incredible was feeling good and willing to participate in physical therapy. He was within functional limits throughout. We deferred performing a manual muscle test on his upper extremities, secondary to having a myocardial infarction earlier that year, because we didn't want to put any stress near the heart. He was 3+ bilaterally for hip flexion, knee extension, and ankle dorsiflexion. And his left knee flexors and ankle plantar flexors were stronger than his right, secondary to his CVA that he had 50 years ago. Light touch was intact throughout, with the exception of his right upper extremity, which had diminished sensation. This was also because of his CVA. Mr. Incredible was able to go from supine to sit with the head of the bed elevated using bed rails to pull up with his left arm with supervision. However, going from sitting on the edge of the bed to supine required min assist of 1 to help with his lower extremities. Sit to stand required min and mod assist of 2, while stand to sit only required contact guard. Mr. Incredible was able to sit on the edge of bed with his left upper extremity being used for support for 10 minutes while performing low extremity exercises. So for example, long arc quads or hip flexion. Before beginning ambulation, Mr. Incredible's vitals were taken and they were all stable so we could proceed. Mr. Incredible ambulated 25 feet with a wide base of support, decreased coordination using a straight cane and min assist of one and contact guard of another. Mr. Incredible experienced some shortness of breath during and after ambulation, but once he sat down, his vitals went back to normal and he was able to breathe normally after about 1 or 2 minutes. Based on this initial evaluation, Mr. Incredible demonstrated decreased strength in both his lower extremities as well as decreased endurance following ambulation and decreased coordination, and will benefit from therapeutic exercises, balance training, and gait training to address those deficits. The plan was to try to have at least 3 visits from PT in 1 week prior to surgery to work on functional activities as well as strength and educate Mr. Incredible on the importance of staying active and mobile. Some activities which were performed were ankle pumps, heel slides, short arc quads, long arc quads, and sitting balance, both static and dynamic, which was timed. These were the goals set for Mr. Incredible prior to surgery. Mr. Incredible showed enormous improvements after only 4 PT treatments prior to surgery, which again just demonstrates the type of motivation this patient had. Now, after surgery, Mr. Incredible had difficulty breathing on his own and therefore was intubated. The plan was to have physical therapy when he was extubated. Although we technically could have performed PT while he was intubated, I guess it was the surgeon's preference to wait until after he was extubated. So the plan was to slowly wean Mr. Incredible off of the respirator. On June 30th, 2007, which was 5 days after surgery, Mr. Incredible tolerated some continuous passive airway pressure, also known as CPAP. Mr. Incredible was finally extubated several days later on July 4th. Mr. Incredible was still in the intensive care unit when my CI and I went to reevaluate him. He had caught an E. coli infection after surgery, so before treating him, we had to make sure that we gowned up appropriately. One of the major differences from prior to surgery to post-surgery and in the ICU was all of the lines and equipment Mr. Incredible was connected to. It was very important to note where everything was before any movements could be made because you didn't want to pull anything out. During the reevaluation, Mr. Incredible had no complaints and was well aware of what had happened. His range of motion continued to be within functional limits throughout, and we continued to defer upper extremity strength testing. In terms of his lower extremity strength, he remained a 3+ out of 5 bilaterally for hip flexion, knee extension, and ankle dorsiflexion. However, his right knee flexors and ankle dorsiflexors went down to a 3+ out of 5, and his left knee flexors and ankle flexors went down to a 4 out of 5. Mr. Incredible's sensation remained the same. Mr. Incredible could roll to the left side with min assist of 1 using bed rails. He required max assist of 1 compared to contact guard to go from supine to sit and sit to supine. He required max assist of 1 compared to mod assist of 1 to go from sit to stand. And from stand to sit, he required min assist of 1 compared to being able to perform this action independently prior to surgery. Mr. Incredible was able to sit on the edge of bed with min and mod assist of 2 for 5 minutes. He required moderate assistance anteriorly to prevent him from falling forward and minimal assistance posteriorly and to prevent him from falling back. Mr. Incredible could only perform longer quads on the edge of the bed for 1 minute before losing complete balance. Before ambulating from the bed to the chair, the Foley catheter had to be moved and all of the lines had to be observed to make sure that nothing was tangled or too short. It's important, Mr. Incredible ambulated only 4 steps to the chair using mod assist of 1. It's important to understand that Mr. Incredible was not fatigued after this movement and his vitals remained stable. He may have been able to ambulate further, but he was tethered down by all of the wires. It's important to recognize how much of a decline a person can have from not moving around for several days, as was the case for Mr. Incredible, which also explains the importance of getting patients strong as possible prior to surgery. Based on the reevaluation, Mr. Incredible will benefit from PT to address his decreased strength, balance, bed mobility, and ambulation. These were the goals to be met in the next 1 to 2 weeks. Although the last one, ambulate 100 feet, may seem as a stretch, our idea was that he would be out of the ICU and he'd be into a regular room and not be on any wires, and that's why we put that on. On July 11, 2007, Mr. Incredible was transferred to a regular room. Another therapist continued to work with him, and he continued to show remarkable improvements. Mr. Incredible was transferred to a local acute rehab on July 23, 2007. I chose practice pattern 6B, impaired aerobic capacity and endurance associated with deconditioning, as the most appropriate for this patient, given the risk factors listed. I bolded the ones pertaining to Mr. Incredible: cancer, cardiovascular disorders, and neuromuscular disorders. Mr. Incredible could not have made it this far without the help of these other services: medical doctors who performed the surgery, nursing who took part in monitoring his vitals, especially while in the ICU, and who also helped with positioning while he was intubated, and gave advice to other healthcare professionals as to what his status was on a daily basis, respiratory therapists who worked to wean Mr. Incredible off of the respirator, occupational therapists who worked to improve his ADLs, nutritionists who assured that he was intaking the appropriate amounts of calories each day, and case managers who helped to place Mr. Incredible in a local acute rehabilitation facility. In conclusion, when working with any patient, especially one with a variety of cardiac complications, you want to monitor their vitals at all times. After working with Mr. Incredible, I learned that regardless of how many comorbidities a patient may have and how old they may be, if they have motivation and a strong team of healthcare professionals working with them to get better, anything is possible. Mr. Incredible was indeed an amazing and incredible patient to work with, and it was a pleasure to have gotten the opportunity to meet him. Thank you. Any questions?
All right. Just wondering, the ICU that you treated him in, I was just wondering how aggressive they were philosophically. Was it a place that tended to treat most people bedside? You mentioned the doctor didn't want him seen until after he was extubated. Was that, did you feel that was the facility or just that doctor? Did they treat people in the ICU?
I didn't see many patients in the ICU. I didn't see many. He was actually the only one, so I don't know if they were just like that with him or with other patients.
Do you know what I'm saying, though?
Yeah.
Like,
So I'm not sure, and given the way he was prior to surgery, you would have thought that they would want him to be seen even while he was intubated, because he was so.
Do you think it was him specifically or the doctor more conservative in general?
I think it was a doctor who was more conservative. Yes.
Given that Mr. Incredible was in the hospital nearly a month, if not a little over, Did you see that he was able to return to his baseline status, or did he decline over the weeks?
Well, I
Once he was
actually,
in the room?
my CI and I didn't actually continue to work with him. Another therapist worked with him, but they stated that he was improving on a daily basis before he left to a local rehab.
Thanks.
Any other questions?